Welcome to AETCM, the emergency medicine channel. Today's our topic of discussion hernia from the chapter of gastrointestinal emergency. I think this is the last presentation in this emergency. And then content of our presentation, introduction to the hernia, what are the common causes, and then classification, and then what are the clinical manifestation, diagnosis, and then management part. Finally, complications also we added. So coming into introduction to the hernia, first what is mean by hernia? Hernia means it is a abnormal protrusion of the organ. Okay, it is a abnormal protrusion, or you can say, tell as a bulging of the organ. So here we mentioned as a organ. So whether that might be a esophagus, or that might be a stomach, or that might be a small intestine. So whatever thing that can involve, but the thing is abnormal protrusion. So or abnormal bulging of the organ from the normal area, it will protrude to the outside area, or it will protrude one area to the other part, that is called the hernia. So still more in a descriptive manner, here we are given a hernia is defined as the protrusion of the viscous or part of the viscous. Viscous means viscera, so that is only we mentioned as a viscous, means again organ. So through a point of weakness or defect in the wall of its containing cavity, through how the protrusion is happening means through the weakness point. So normally that muscle group or some other area, it will protect from the protrusion, so it will prevent the protrusion. But if any weakness happens means through that area the organ will reach out the other part, that is the through a point of weakness, or the where the present in that cavity there will be a problem in the defect. Okay, defect in the wall. So what are the causes? So as like we told, whenever the pressure is increasing the abdominal cavity, mean the same time it should accompany with a combination of weakness. Okay, the both things should be there. So muscle weakness also will be there, or instead of muscle weakness, in that containing cavity there will be some defect will be there, along with increased abdominal pressure or increased pressure on that cavity. Okay, so that which are the things that will increase the abdominal pressure? Intra-abdominal pressure means while the straining that is because of the defecation, at the time of defecation or micturition, or while lifting that heavy weight. So those are the things comes under the straining part. Obesity also one of the cause, and then family history also one of the factor that will comes under the etiology of the hernia. Okay, the both factor also most important. So first thing, there will be a increased intra-abdominal pressure, mean the same time the defect or the muscle weakness will be there, because that more crucial factor or the culprit here is that weakness of the muscle. Okay, and then hernia, how we are classifying means two classification we have based on the anatomy, based on the hernia content, and then content that reducibility of the content. Okay, and then based on the anatomical location we have a internal and then external. Internal means, so visibly we can't see any bulginess, or visibly we can't see any protrusion of the organ, that is will comes under the internal category. So inside the body itself there will be a protrusion of organ will be there. External means visibly we can see the some amount of bulginess, or visibly we can see the protrusion of the organ, that comes under the external. What are the common example we can tell for the internal means, and that hiatal hernia, diaphragmatic hernia, those are the things will comes under the internal hernia. So external hernia means, so our femoral hernia, inguinal hernia, so the umbilical hernia, and then incisional hernia, so those are the things will comes under the external hernia. Okay, and then coming into second classification based on the reducibility or based on the status of the content. So based on that we can classify into reducible, strangulated, incarcerated. So we'll see one by one what is mean by each. So reducible means, so the same thing. So simple term, reducible means we can easily revert back the content in a normal position by giving the manual pressure. Okay, so if you are giving a manual pressure over that bulging area means easily it will reduce, or easily it will revert back into the normal position, that is the reducible. Second thing, that is a irreducible or non-reducible condition. That condition is called as a incarcerated. So incarcerated is a non-reducible by the manual pressure. By the direct manual pressure, if we unable to replace the content or revert back the content, means that is called as a incarcerated. Okay, and this is little more painful. So what will happen? So incarcerated hernia we discussed in the bowel obstruction once a time, right? Last presentation, I think. In last presentation, we told incarcerated hernia is one of the example for the closed loop bowel obstruction. So we told closed loop bowel obstruction means, so what will happen in incarcerated? There won't be any escape point through the proximal or the distal region, means, so in the time of hernia what will happen? So that loop some of the part of the organ will protrude outside. Okay, in this time what will happen? So that whatever content that is present inside that intestinal, that outside in the protruded part, whatever intestinal content is there, that it can't escape through the distal route and then proximal route. Both route will be blocked. Okay, this is called the closed loop bowel obstruction. This is the one of the example of the closed loop bowel obstruction is one of the example of incarcerated. So we told like the bowel content can't escape or unable to escape through the distal route or proximal route. Both routes are blocked. So in this time, so we have to think, we should not think about the bowel content, we have to think about the vascular also. So vascular also what will happen? So over the time the resistance to the blood flow also will increase. So if the resistance to the blood flow will increase, means what will happen? Automatically the blood supply to the area, that specific area will reduce. So blood supply reduce means automatically it will develop ischemia. So over the time ischemia continuing means, then what will happen? It automatically the area will necrotize and then gangrene formation and then leads to the sepsis and then septic shock, bacterial growth, everything will happen. So this is the state where the blood compromise and then vascular compromise occurring, means this state is called the strangulation stage. Okay, so from incarcerated it will developing into strangulation state. When it is occurring, whenever the compromise in the vascular supply, vascular and then lymphatic supply is occurring, means then it will move into the next stage. Next stage, that is called the strangulation. Strangulation means that is a type of suffocation, right? So here the suffocation in the blood supply, okay, vascular supply, it is one of the acute surgical emergency condition. So these are the three stages. Reducible mean easily we can revert by the manual pressure. If we unable to reduce or revert back, mean that is called the incarcerated. And then one of the complication of incarcerated is a strangulation. Okay, then that image also we can see the different parts of hernia. The hernial sac here we can see, and then we have that hernial neck. So this is the most important, that hernia neck is most important part while we are doing in the management. So this two thing I think we can remember is the parts of the hernia. Then we are moving on to the based on the anatomical what are the common hernias we are encountering. So first thing we are going to see the inguinal hernia. Okay, before getting into the inguinal hernia, we'll see some anatomical note regarding the inguinal region. So where is the inguinal region? That's the first question. Inguinal region is also known as the groin region. So both terms are same only. So inguinal means other name for the inguinal region is a groin region. Second point, where it is, exactly where it is means it is the lower part of your abdomen. So here in this image you can see this is the lower part of your abdomen. So okay, so it's a lower part of your abdomen. Second point, inguinal hernia. So inguinal then coming into inguinal hernia, inguinal hernia is a one of the subtype of groin hernia. Okay, so we have a different types of hernia, like we told hiatal hernia, and then we told abdominal hernia, and then one in that one type is a groin hernia. In groin hernia we have two different types. One is a inguinal hernia and then another one is a femoral hernia. Okay, so in again in inguinal hernia we have a again subtypes also we have, that is the direct inguinal hernia and then indirect inguinal hernia. So these are the two subtypes of inguinal hernia. Okay, so then now coming into inguinal hernia, we'll see what is meant by direct inguinal hernia, what is meant by indirect inguinal hernia. I think I can draw one image, thereby you can understand so easily. Just a minute. So here, so we'll draw an image how our structures are organized from internal to external. So we'll draw one by one, the structures are one by one. First, inside we have your intestine. Okay, this is your intestine, and then followed by we have a structure of peritoneum. Okay, first we have a intestine, and then followed by that in front of the intestine we have a peritoneum, and then before the peritoneum, what have in front of the peritoneum we have a some other structure called the transversalis fascia. Transversalis fascia. Okay, so this is the one of the connective sheath, and then we have a muscle group like a internal oblique muscle group, and then we have a second one, that is the external oblique. Okay, then we have a, in outer region we have a one more sheath we have, that is called the aponeurosis. So your aponeurosis of external oblique. Okay, external oblique group, muscle groups, aponeurosis. So these are the structures that is aligned from internal to external. So you have to imagine, first we have an intestine, then we have a peritoneum, then we have a transversalis fascia, then we have a muscle group like a internal oblique, external oblique, and then finally we have a aponeurosis. In this area we have a, so if you want to discuss, if you want to understand the concept of inguinal hernia, you should remember the two major important things. Okay, first one, you should remember the where the inguinal canal, second one regarding the anatomical note regarding the inferior your epigastric artery. These are the two major structures that is we have to remember while distinguish between the indirect and then direct hernia. Okay, so in this area you just remember this area. Here only we have a structure of your this one inguinal canal. Okay, so inguinal canal is nothing but it is the area, this is the canal that will bring out your this genitourinary or genitalia content, means the related within your reproductive system content, means so in this through in male cases through this that through inguinal canal your spermatic cord will come out. Okay, cord, spermatic cord will come out through the inguinal canal. In the case of female, there is one ligament called circular ligament that will come out through the inguinal canal. So this is the main pathway for your genitourinary or mainly for the reproductive content will come out. Okay, so this is called the inguinal canal. Okay, and then here one more thing we have a first thing we told the regarding we should remember the inguinal canal. Second thing, here only we have a your epigastric, inferior epigastric artery. So these are the two structures we have to remember. So then we'll coming into the indirect and then direct hernia. How we are differentiating indirect and then direct hernia. First we will see the indirect hernia. In indirect hernia what will happen means that a bowel or that protrusion happen through the inguinal canal. Okay, the protrusion happen through the inguinal canal. So through this your small intestine will come out and then it will reach out your scrotum. Okay, in the case of male. So if it is in the case of female means it will protrude through your vagina. So that is the indirect hernia. So through what? Through the inguinal canal. Okay, the one more thing in the inguinal canal, so this is presenting more deep in the structure, so they will call as a deep inguinal canal or deep inguinal ring. Okay, then this is presenting somewhat superficial, so they will call as a superficial inguinal ring. Okay, okay, this two things also we have to remember. So in indirect inguinal hernia what will happen means that bowel or that protrusion happen through the inguinal canal, mainly through from the deep inguinal ring to the superficial inguinal ring, then it will reach out the scrotum or vagina. So this is what will happen in the indirect. But what will happen in the direct means it won't reach out through the deep inguinal ring, straight away it will approach the superficial inguinal ring. By what means if there is any defect in that transversalis fascia means, So through that it will penetrate through the transversalis fascia, and then it will reach out your superficial inguinal ring, thereby it will reach out the scrotum or vagina. So this is what will happen in the direct inguinal hernia. So first it is approaching the weaker part of transversalis fascia, through that it will reach out the superficial inguinal ring, through that it will reach out the vagina or your scrotum. So this is what will happen in the direct hernia. And then coming into relation with your inferior epigastric artery, inferior epigastric artery. So indirect hernia, so this is the inferior epigastric artery. So your indirect hernia is lateral to the inferior epigastric artery. So it is a lateral to the inferior epigastric artery, but coming into direct hernia, it is medial to the, usually it will happen like this. So it is medial to the inferior epigastric artery. So this is the two factor that will distinguish or differentiate between the indirect and then direct hernia. So by this view, if you are seeing this slide, means it will be easy for you. So direct hernia, the hernia passes directly through the weakens in the transversalis fascia. Okay, so that's the thing we told. So it is medial to the inferior epigastric artery. Coming into indirect hernia, it is protrude through the internal inguinal ring, internal or deep inguinal ring. So both are same term only, and then it is lateral to the inferior epigastric artery. So remember that image, by that you just see this slide and then you will catch up something. So here something they were mentioned like a Hasselbeck's triangle. So it is nothing but Hasselbeck's triangle. So in the medial part you will have your rectus abdominis muscle, and then lateral part you will have your inferior epigastric artery. In that inferior portion you have inguinal ligament. So this is called a Hasselbeck's triangle. Hope you got something. So this is the direct and then indirect pictorial demonstration. And then coming into next hernia, that is the ventral hernia. So what does mean by ventral? Ventral means abdominal. So abdomen only we are calling as a ventral. So it is an abdominal hernia. It develops as a result of defect in the anterior abdominal wall. It can be either spontaneous or acquired causes. Mainly based on the anatomical region, we are calling as a, whether that is the epigastric or hypogastric or umbilical hernia. Okay, based on that area we'll call as a epigastric, umbilical, incisional and then hypogastric. And then next is the incisional hernia. So incision means we know because of the any surgery, so some rather time the person may gone through the some other surgery, abdominal surgery, or some rather time because of the hernia also he can go for the any herniography or hernioplasty. Through that also it can that organ can protrude outside. Okay, that is called the incisional hernia. It is main risk factors are obesity, age, wound healing, medical condition like a chronic obstructive pulmonary disease, because these are the things will increase the intra-abdominal pressure. Already there is a defect in that containing wall, so easily the organ will protrude out. So and then it can be become a quite large, and then it produce symptoms varying from the discomfort to the extrusion of abdominal content to the incarceration and then strangulation. Despite primary repair, incisional hernias can recur. So this is one of the statement you have to note. So umbilical hernia, the same thing. Through the umbilicus, your portion of the bowel or portion of the small intestine will protrude. So that is called the umbilical hernia. Here the strangulation is more unusual. Means the vascular compromise, it is a little bit rare one, but where it will present continuously means those who have a chronic ascites cases, there is a chance of strangulation, rupture and then peritonitis can occur. When coming into next one, hiatal hernia. So what is mean by hiatum? So hiatus means we know that is the opening in the your diaphragm. So we have a three major openings we know. That is one. First one is we have a caval opening, caval hiatus, that is for your inferior vena cava, and then we have for your this one esophageal opening, and then we have for the aortic opening. So through this esophageal opening, what will happen? So your esophagus and then part of your stomach that will enter from the your intra-abdominal to the intrathoracic area. So that is called the hiatal hernia. So two ways are there. First one, sliding and then rolling. Sliding means easily it will slide and then it will go into the thoracic cavity. Rolling means by the way of rolling. So part of the stomach, it will go into that thoracic cavity, mean the same time it will twist. Okay, this is the thing which will happen in the sliding and then rolling hiatal hernia. Then what are the clinical manifestations? Mainly if the hernia is a small and then moderate size, means it won't produce any other major signs or symptoms. If it is a large hernia, or else if it is going into incarcerated or strangulation status only, it will produce more vulnerable symptoms, like where the person may feel discomfort while coughing, or while going in defecation or micturition state, or if he or she lifting any heavy object, means they will feel some set of discomfort or pain. And tenderness will be there, bulging will be there, severe symptoms and then severe sudden pain, nausea, vomiting, constipation also will be there because of the bowel obstruction. Some rather time abdominal distension also chances are there. So diagnosis wise, traditionally we are going with an CBC, serum chemistries and then urine analysis, routinely order. These are things we will commonly do, either to rule out infection related, mean the same time we have to go for the, if the person need any surgical exploration also, for that reason we can go for. And then imaging wise, plain films are not required to hernia patient without significant symptoms. So that abdominal series can reveal for the free air, because if you want to rule out or if you want to check for any bowel obstruction related, then you can go for the plain film of chest x-ray. Then we are coming into ultrasonography and then computer tomography. So USG is a POCUS or point of care ultrasonography is a more useful diagnostic manner in the ED. Okay, mainly in the ED it is more useful. How it is helping us means, so you can by the ultrasonography you can see the size of the hernia, you can see the content of the hernia, and then whether we can reduce or not, that we can check. And then location of the facial defect, tenderness also we can check. So if you want to check for any vascular related compromise is there or not, that you can go with an Doppler ultrasonography also, it's a provision is there. And then if you want to check any incarcerated hernia, means there you can check the thin walled veins and then lymphatics become compressed and then compromised before the thick walled arterial supply. So these are the some features that we can go through via the POCUS or point of care ultrasonography in the ED. Coming into CT, that is mainly useful in the case of some uncommon hernia types like obturator hernia. So obturator canal, through that organ can protrude. So some uncommon hernias that we can go with a computer tomography. And then what is the treatment? Mainly considering about the pre-hospital, don't try to reduce hernia in the pre-hospital for at any cost, because we don't know whether that is a simple hernia or incarcerated or strangulation. So if some rather time, if the person may have a strangulation, okay, without knowing that, if you try to if you are attempting to reduce that content, means what will happen, some rather time it can perforate. So if it is perforated, means what it can land up into other complication. So whatever content inside that hernia, that will spread all over the peritoneum and then it may lead to the sepsis and then septic shock. That is why don't try to reduce in the pre-hospital. Once if we reach out to in-hospital, from there from in-hospital also they will go through for the lot of imaging testing, then only they will go for the reducing. Like we told, ultrasonography is one of the equipment, then only they will. So if no vascular compromise is there, they were confirmed only, then only they will go for the reducibility, they will think for the reducibility. That is why we should not attempt anything. Instead of that, what we can do in the pre-hospital, so pain management we can think about. Second thing, if any sepsis or septic related things happen, means so hypotensive if you are encountering, means then you can take over that hypotensive management things. And then the positioning of the person also you just take care. And then don't put any pressure over that region, and then don't apply any cold packs over that region, because normally if we are seeing any swelling, means we will use to place some ice packs, right? That should not be done in the hernial area. So remaining things and all symptomatic related, not we are not going to focus on that hernia related things like reducibility things. What we are doing in the in-hospital means the same thing only, so that we told fluid administration, and then if any hypotension sepsis related mean that we will take care. Antibiotics, appropriate antibiotics we will go for, and then we will obtain the preoperative laboratory studies, like if we want, if the person need for the surgical exploration means, then preoperative laboratory studies, and then narcotic analgesic everything will go for. And then again we told how they are going to how we have to reduce the hernia means. So there are some sort of method is there. First you have to keep the patient in the NPO. So NPO but for condition. So again if we can't reduce means, so we have to taken up patient for the surgical exploration, right? For that reason you have to keep for the person in the nil per oral state, and then we have to adequate IV narcotic analgesic we have to administer. The same thing, we should not apply any cold packs on the hernia site to reduce the swelling or make reduction attempts easier. And then so how to reduce means, so think that is the, so this is the abdominal wall, and then this is what your hernial sac, okay, hernial sac. So here you have to place one hand over this area. So this hernial neck area you have to place one hand. With the other hand you have to try to reduce from the proximal portion. So in this neck area you have to try to reduce means you have to partly, so how I can, so you have to partly insert the protruded organ slowly into the abdominal content. The area we told proximal, okay, or near the hernia neck site. You should not put pressure over the distal area. What will happen if you are putting pressure over the distal area means, because of that if you are keeping pressure over the distal area means, it will cause this bulging or ballooning of the your hernia content will occur. That is why, so you have to place one hand over that neck area, and then you have to tightly film over that area, and then you have to apply small pressure, or you have to revert back the content in the proximal area or near the neck area. You should not put pressure over the distal area. So this is what we are keeping here. So better to, so if the experienced physician is there means, they will go for, and then or else they will call for the help of surgery people, general surgery people. And then we have to better to go than general surgery people. And then this is the some set of management, non-surgical management dress. This is mainly for the inguinal hernia. So this is nothing but this is one of the pad we will apply externally. So it is some, what I can tell, so it will provide externally, it will put pressure over that weakness area. That is the thing. So what we are doing in the bleeding or what we are doing in the splinting cases, same thing only. So externally in that weakness part, it will externally put pressure over that area, thereby the organ won't come out. So this is the one of the pad we have. A surgical management wise, we have a herniography and then hernioplasty also. So complication wise, irreducibility, because of the irreducibility, the person may develop into adjacent edema, sliding hernia, impacted fecus, and then narrow neck. So and then other causes, other complications like obstruction, incarceration, strangulation. So this is the area. It may lead to the sepsis, and then septic shock, multi-organ dysfunction, everything will occur. So rupture of the sac also can happen. So this is also we have to keep in mind while handling in the pre-hospital or in-hospital. So we should not put pressure, or we should not turn over the patient. So we have to ask the person to avoid into the lying on the hernial side. So because of that pressure necrosis or trauma, that rupture also can occur. Fistula formation also chances are there. So do your best. Shalom.